Start, sir. Yeah. So, hello and very good evening, everyone. I am Dr. Ajinkya Nanare from Emcure Pharmaceuticals. I welcome everyone to yet another session of the very well-known No Thrombosis workshop in acute ischemic stroke. Basically, the objective of this workshop is to showcase unique cases in the management of acute ischemic stroke and gain insights from our respectable moderators and wisdom shared by our course director. In the previous workshops, we had a very unique and interesting case discussions, and we are looking forward to have a fruitful discussion today as well. And it is my honor to introduce our faculty members for tonight. So let me share my screen. Yeah. So I first welcome our course director for tonight, Dr. N.R. Ichapuria sir. Sir is Director Neurology at Sahyadri Hospital, Pune. Sir has the first neuro ICU and neuro intensive care of Pune. He has been a pioneer in thrombolysis treatment for stroke in India. Sir has more than 300 public lectures and workshops on stroke. He is a member of Indian Stroke Association and the organizing president of StrokeCon 2012 and ISH Stroke School. Sir is a founder of Pune Stroke Group and ex-president of Society of Neurosciences Pune and Maharashtra Academy of Neurology. He has been principal investigator for many multinational stroke trials like Perform, BrainsGate, and etc. He has been awarded as the health icon by the Times of India Group recently. Welcome, Ichapuria sir, to this interesting session tonight.
Thank you. Thank you so much.
Then I welcome our first moderator for tonight, Dr. Anshu Rodki sir. Sir is consultant neurologist at Sir Gangaram Hospital, New Delhi, and professor of neurology at Gripmar, New Delhi. He is a secretary of Delhi Neurological Association from 2021 onwards. He is a joint secretary of Association of Neurologists in Clinical Research, Mumbai, coordinator for the National Accreditation Board for Hospitals and International Organization for Standardization for Neurology. He has been a principal investigator in more than 24 studies like VitaTop, Profess, etc. Sir has over 47 publications in various reputed national and international journals. He has presented more than 25 scientific papers at various conferences, and he has been a guest faculty at many prestigious neurological meetings and conferences. Welcome, sir. Then I welcome our second moderator for tonight, Dr. Fiju Chako, sir. Sir is a professor and unit head of neurology department at Jubilee Mission Medical College, Thrissur. Sir has secured first rank during his PG entrance in 1995 and also awarded as a gold medal during his MD medicine. Sir has done DM neurology from PGI-MER Chandigarh, and Sir has received Best Poster Presentation Award in 2001 Indian Academy of Neurology, New Delhi. Sir is secretary. Sir was secretary of Thrissur Physicians Club for 2005 and 2006. Treasurer for Kerala Association of Neurologists in 2006 to 2010. He has presented at several national and international conferences and has more than 10 publications in national as well as international journals. He has been a quiz master at several conferences, and he also has an informative YouTube channel of his own. Welcome, sir. Welcome for this workshop.
Thank you.
Then I welcome our first expert speaker for tonight, Dr. Keyur Kumar Panchal, sir. Sir is consultant and interventional neurologist at NeuroPlus Brain Stroke and Spine Clinic, Mumbai. Sir has exposure of 700 plus neuro-interventional procedures like cerebral angiography, mechanical thrombectomy for AIS, carotid stenting, vertebrobasilar stenting, aneurysm coiling, etc. He has 3 publications in various journals, and the special interests are stroke and epilepsy. Welcome, Dr. Panchal, sir. Then I welcome our second expert speaker for tonight, Dr. Umesh Chandra, sir. Sir is a neurologist at Ramakrishna Care Hospital, Raipur. Actually, he's in a second year of DNB neurology at Ramakrishna Care Hospital, Raipur, and He has completed his MD Medicine from MGM Medical College, Indore, and MBBS from JNM Medical College, Raipur. Welcome, Dr. Umesh Chandra, sir. So with this short introduction, I would like to hand over this session to our course director, Dr. Ichapuria, sir, for the context setting and his opening comments. Over to you, sir.
Yeah, thank you for the very kind invitations and warm welcome to you, Dr. Chaco. I think this is your first stint as moderator, and I'm sure you'll enjoy the program. We've had now, I think, for over a year, this program has run, and I must say that I've learned so much from everyone, and I've been blessed with, some amazing cases that we have seen, and I'm sure the same thing will happen today. So I'm sure Dr. Umesh Chandra and Dr. Keyur will also present wonderful cases, and we will have a very fruitful discussion. Dr. Anshul has not yet joined, no? So, okay. So he's been a moderator on this program a number of times, and he would also echo the same words that I said. And I would now request Dr. Chaco to say a few words.
Thank you for including me as a moderator. And let us start with the proceedings. We are eagerly waiting.
Little loudly. We can't hear you so clearly.
We shall start with today's proceedings. We shall have the first case, please. Without much delay, we can go into the first case. Dr. Umesh, are you presenting?
Yes, sir.
Shall we go ahead with the first case?
Yes, sir. Good evening, all. Respected senior faculty members. Myself, Dr. Umesh Chandra, second year DNB Neurology student at Ramkrishna Care Hospital, Raipur. Good evening, sir. Today I am going to present topic on strep thrombolysis. This is a case of a 92-year-old male who was presented in emergency room in window period of 1 hour. So basically my topic is stroke thrombolysis in an extreme age patient with higher NHS score. Now case study. A 92-year-old gentleman presented to emergency room with sudden onset left-sided weakness.
Sir, sorry to interrupt, but you can switch to the next page, and then the page will display. You can switch by down arrow in your keyboard.
It is visible?
No. Yeah, it is visible.
Go to slideshow.
Somehow he is not able to start a slideshow. I don't know why.
Is it visible?
You can try selecting that page with your mouse cursor. You can switch to second case by your mouse cursor. Double click.
Yes.
Yeah, it's visible.
A patient of 92-year-old gentleman who presented to emergency room with a history of sudden onset left-sided weakness, slurring of speech, and decreased conscious level, which was for 1 hour, and the incidents happened at around 7 a.m. in the morning. There was significant past history with known coronary artery disease and post-PTCS status. He has history of permanent pacemaker, and first time presented, there was history of paroxysmal AF in past, which was controlled ventricular response, and also patient was diabetic and hypertensive. He was on regular medication with aspirin 75 mg OD, atorvastatin 40 mg in night time, and amiodarone 200 mg twice daily for atrial fibrillation.
Can you speak a little loudly, please?
Yes, sir. He was regular or his antihypertensive and antidiabetic medication. And on his examination, he was conscious following command, and his pulse rate was around 88 per minute, which was in atrial fibrillation rhythm. BP was around 140/80, RBS was 130/134, and GCS score was E3B4M6 at the time of presentation in emergency room. On calculation of NIH's score, his total NIH score was around 18. His speech was severely dysarthric, and there was right gaze preference, and left-sided facial weakness was there, which was UMN type. On motor power examination, there was no power at all in the left-sided limb, which was 0/5.
Just move your slides. Move your slides.
Sir, we can do one thing. Meanwhile, Dr. Umesh Chandra can share his presentation to me, and Dr. Keyur can continue if you allow.
Because we know we need to see the slides.
Yeah. Dr. Umesh Chandra, sir, you can share your presentation to me. I will display it for you. Meanwhile, Dr. Keyur, sir, can show his presentation. So that would be...
Yes, we are stuck at the second slide.
Yeah, that is why.
Yeah, now it's moving.
Or we may do one more try. Now it's the next slide. Yes.
Yeah. Try doing next by your down arrow. Yeah. It's visible.
The NIHSS 18.
Yes, sir. And speech was severely dysarthria was there. And there was some right gaze preference, and left element human facial palsy was there. And his left-sided motor power was 0/5 according to MRC scale. And his deep tendon reflexes was depressed in left-sided limbs. And there was extensor plantar response in the left side and flexor plantar response in the right side. This was first MRI, which was done on arrival at ER, which showed there is a periventricular acute infarct in the right MCA territory, and there was a acute infarct in right temporal region also. On FLAIR image, because patient was wake up around 6:30 and he suddenly developed symptoms at around 7 in the morning. We also did a FLAIR sequence, and the patient was already on antiplatelet and higher age group patient and AF rhythm. We also rule out possibility of any previous bleed. This was his FLAIR image sequences. There was no acute infarct lesion. There was definite diffusion and flares mismatch, and there was no blooming on GRE sequence. In the further FLAIR images, we showed there is a occlusion of right internal carotid artery in his extracranial as well as in the intracranial part. Actually, his right ICA and ICA was completely thrombosed in the both in extracranial and intracranial part, and the intracranial part of thrombosis was extending up to the some part of the right M1 segment of right MCA. Because of patient was on window period of 1 hour and 15 minutes, he was in ER around 8:15 a.m. We decided to thrombolize after ruling out all absolute or relative contraindications. There was a door to needle time of 20 minutes, and we thrombolized this patient with 10 hectoplace, 0.2 milligram per kg body weight. Total dose was around 14 milligram. While thrombolysis was complete, within 15 minutes, patient developed some deterioration. His GCA general condition was deteriorated. GCS was fell down to E2, V4, M6, which was previously 14/15. Now it became 10. In view of recent thrombolysis, we went to rule out the thrombolysis related bleed and decided to go for immediate CT scan to rule out some intracranial bleed. This was his first CT scan. At that time, patient was in emergency room, and we immediately shifted him to CT for ruling out the intracranial bleed. And that time there was no intracranial bleed. The patient shifted to ICU, and he was doing well or vitally stable that time. This was his follow-up CT scan after thrombolysis of 24 hours. Patient developed new infarct in the right MCA territory, and there was also new infarct in the right ACA territory. On the next day, patient clinical condition was further deteriorated. A patient became drowsy, and his pulse rate was little bit higher side, and it was in AF rhythm, and Chadwas score was around 5, which was high risk for the atheroembolic stroke, and his GCS further deteriorated and become 9. And pupil was symmetrical, 2M reacting to light, and motor power in left side remained 0/5. Next follow-up CT scan was done, which was suggestive of there are some hemorrhagic transformation in the ACA territory and right MCA territory. Meanwhile, patient was vitally stable, and he was little bit conscious, and with GCS score around 10, 12. And on 12th day of admission, it was decided to discharge this patient. He was vitally stable, but there was some residual weakness in the left side, and dysarthria was present. His Hasbled score was 5 at the time of discharge. So we were not included anticoagulant in his final discharge. And patient was discharged in aspirin 75 mg, atorvastatin 40, amiodarone 200 BD, and metoprolol succinate 25 mg OD. This all about my case. Now I have few points for discussion with the senior neurologist. My first point for discussion is, in this type of cases, if thrombolysis with recombinant tissue plasminogen activator in old age patient who are already on antiplatelet or anticoagulation therapy, what should be the base modality of treatment if patient is in window period?
We need not consider the chronologic age. If the patient, what about the functional status? If the patient is walking, talking, and age is no bar, if they are 90 or 95, if they are going for a morning walk and they are independent, we need not say consider 80 as a cutoff and avoid thrombolysis. In the elderly, the senior group also, thrombolysis is beneficial. So even if age alone is not a bar for contraindication, they say beyond 3 hours the risk is more.
Sir, some patients who are already on like dual antiplatelet or some anticoagulants for other diseases.
Dual antiplatelets, the risk of bleed is high. Obviously, if they are on dual antiplatelet, the risk of bleed is higher. But still, if you get them within sweet spot like 1 hour, the risk is less. The benefit will be more. But here the problem is MCA plus ACA. Once you have an MCA plus ACA, what do you consider? Which vessel? Is there a blurring of vision on one side, the right side?
Patient was a little bit drowsy. He was not able to answer all the questions that time. It was difficult to ask for visual symptoms.
Since there is anterocerebral and middle cerebral, is it an internal carotid?
Yes, sir.
Is the ophthalmic artery spared or involved?
Patient was like his GCS was around 10, 11, so it was little bit difficult. He was drowsy, even not fully cooperating with investigations too.
Yeah. By day 4, day 7, is there a midline shift? Did we have to consider?
No, sir. On follow-up CT scan, there was no significant midline shift was there, and just there was some hemorrhagic transformation was there, and there was no significant midline shift.
The heart rate was 100 and patient was in fibrillation, atrial fibrillation.
Yes, sir.
Was an echo done, and did we rule out a LA clot?
Yes, sir. On first day there was 2D echo was done, which was suggestive like there was no LA clot, and EF was around 55%. There was no LV apical clot.
So we have an atrial fibrillation patient on pacemaker. The patient was on pacemaker, which was MRI compatible.
Yes.
Now, recently we have MRI compatible pacemakers. Yes. Or did we have to switch it off and get the MRI done and switch it on again? Probably that's MRI.
Yes, sir. Patient was on MRI compatible pacemaker. It was the first MRI also done in the emergency, and pacemaker was on active mode.
One, like we say, mathematical formula. If the ACA plus MCA is there, it could be the ICA, it could be proximal. And very often we have the ophthalmic artery also involved.
Yes,
but if it's a MCA plus PCA, what could it be?
Cardioembolic.
Again, it could be a fetal PCA.
Yes.
The MCA itself might be through the PCOM continuing as the PCA. It could be the fetal PCA. Then a large MCA alone will have combined involvement of MCA and posterior cerebral also. Here it's a case of ICA in AF, no LA thrombus.
Okay. Sir, my second point for expert.
No, just let your first point.
Yes, sir.
Just get back to that.
Yes, sir.
See, thrombolysis can be, there is no upper age limit. At one time there was, 80 years we used to say, but now there is no age limit. You can give it at any age. That means above, according to guidelines, above 18 years, up to any age. So that is not an issue. Older people also do well. Between 80 and 90, they definitely do well, octogenarians. But above 90, how they respond is still very unclear. But probably they don't do as well. So, but it's not a contraindication. It's not a contraindication, but they don't do so well because of advanced age and because of maybe other comorbidities that they may have. So it's not a contraindication. You can give it, but perhaps you tell the family that yes, because of his extreme age, he may not do as well as other people. But 80 to 90 definitely do better. Then secondly, antiplatelet, single antiplatelet you can give. Double antiplatelet also you can give. There is slightly increased risk of bleeding, but it is not a contraindication, especially if it is aspirin and clopidogrel. Now, we don't have data on aspirin and Brilinta. Suppose patient is on Brilinta, we don't have data. So we can't answer that question just now. But perhaps you can give, the date, because it's a relatively new drug for us. So, the data is not generated. It'll take time for the data to be generated, but perhaps you can give. Usually what I do in these patients, one is always a little unsure. So we give a lesser dose. I don't know, this is outside the guidelines. Don't quote me, but, this is what we do, especially when, there is advanced stage and dual antiplatelets in the system. We give half the dose. Not half, we give 0.6 mg of actylase. And so maybe, because we are frightened, so I don't know whether that is correct or not, but that is what we do frequently. Anticoagulation, the thing is that if he's on warfarin, the INR should be equal to or below 1.7. So very quickly, especially with a point of care machine, you could do the INR. Otherwise, you send it to the lab and you waste another half an hour, 45 minutes easily to get the report. So, in this particular case, this point of care INR is reasonably accurate. It's not very accurate, but it gives you a general idea that whether you should thrombolize or not. Now, question comes with the NOACs, whether you should give or not. So this is again a difficult issue. What we do in our setting, it's difficult to get the thrombin time and to do the assay of the drug, like, what the literature says. It's impossible in our setting. So what we do for dabigatran is we look at the PTTK or APTT, and if it is more than 40, and if the tablet has been taken within the last 24, 48 hours, and the APTT is more than 40, we consider that the drug is in the system, and we may want to give antidote for this therapy, for this patient, and then give thrombolysis. We have done this in 2 or 3 patients. Idaruxizumab we can give. But it's a rare occurrence, but not that it doesn't occur, it does occur. Now, a problem comes when, apixaban is there and rivaroxaban is there. So with apixaban, ideally one should, APTT is not a good thing. You should do the PT. And if the PT is high, means the apixaban is in the system. And though we don't have a direct antidote, maybe we can use PCC and reverse these patients and then give. I've never done this, but and it's theoretical. And if you see the literature, they would say that it's contraindicated. But I mean, for literature to be generated, it takes time. So don't quote me really, but perhaps, in my mind, I've thought that if I get a patient, I've not got a patient of this type yet, but if I get a patient of this type, this is perhaps what I would do. I don't know, Anshu, and
I think
what would you think on this gray area?
Yeah, I think I will just start from the first point. So I think patient more than 80, we are also using 0.6 only because we are worried about the bleeding. And especially most of them usually have some underlying cardiac disease, so they are on single or double antiplatelets. So we are using 0.6, although so that is number one. Number two is I have used Prexbind in 2 patients who were on dabigatran, and we have thrombolized them very, very successfully. So it works, Prexbind, but unfortunately, I think now the availability is quite questionable of Prexbind also. Now, and I have used PCC in 1 patient who was on apixaban, and so we have used PCC in the past. And I think as far as thrombolysis in the elderly, I think the age limit is now no longer a criteria. I think what Dr. Chaco was saying was that the functional age is more important. What was the quality of life that the patient was having? In fact, actually, I had thrombolized my own father. He was about 87, so last year, and we had in fact used tenecteplase only. So I think age is not a factor. I think the functionality of the patient is what is more important. And I think it's now very well established that one can use thrombolysis in patients who have got on single and double antiplatelets. Of course, with Brilinta, I think our experience is very, very limited as neurologists. And anticoagulation, of course, their standard guidelines 1.7.
Similar low dose is used in tenectase. TNK also 0.16 or 0.15 would suffice if there is a higher risk of bleed.
Yeah, perhaps, I don't know. I've not used TNK in lesser dose, but
I think anyway, we are using already a lesser dose. We are using 0.2, and actually now the new dose is 0.25.
Yeah. No, but we should use 0.25
actually. So we have been using 0.2 for the last few years. I think now the newer dose, I think 0.25 would be a better dose.
I think so. Yeah. Okay, we'll go on to the next point that you have.
My second point is, in case of large infarct with large vessel thrombosis, when to start anticoagulation after thrombolysis? Like patient is already in AF rhythm and a large infarct.
Yeah, so, this is that standard Diner's rule, the 0, 3, 6, 12. So we follow that rule. So, if it's a large infarct involving entire MCA, then wait for 12 to 14 days. If it is 1/3, then maybe wait for 6 days. If it's less than 1/3, 3 days. If it's a TIA or minor stroke, start on next day. So we follow this rule, but I tend to feel that, we should not delay too much. And now there is data to say that earlier you start, the problem with waiting is that you are risking the patient for a restroke, especially if he has got AF. So you have to balance the two, whether, you're worried about hemorrhagic infarct or you're worried about restroke. So by and large, I think this 12 days and 14 days, a little too much. We tend to do it maybe at the end of the first week. And we've not been unsuccessful, and we've not had an increase in bleeding, hemorrhagic conversion. So though this law is there, and I don't know if it's in the guidelines, I think somewhere it's in the guidelines, but we tend to use it a little earlier rather than later.
So without that, we didn't start anticoagulation in this patient, and after 24 hours, there was some hemorrhagic transformation in infarcted territory.
Don't worry about small hemorrhagic transformation. That is normal. That is because of reperfusion. So it's not symptomatic. So we shouldn't worry too much about it. I mean, almost every case, if you do a CT scan, MRI, to every case you will find small little petechiae. So don't worry about these. I would restrict myself to CT scan, and if it shows hemorrhage, so you have to distinguish between parenchymal hemorrhage and hemorrhagic infarct. So if it is a small petechial hemorrhage, don't worry. Nothing is going to happen. You can start aspirin as per this schedule, or maybe in a day or two. If it's large infarct and little, maybe you can wait for aspirin for another 2-3 days. But earlier you start, the better, I would feel. And not to worry about these small little specks which occur.
Sir, my last point is, after thrombolysis in elderly patient with high NIH score, there was no age limit, as sir told already. I want one question. In this scenario, there was already complete thrombolysis in the ICA part, which was in extending from the extracranial to in some intracranial part also. We are already knowing this, like there is a large thrombosis. Should we go for thrombolysis, or mechanical thrombectomy would be more helpful in this case?
See, when ICA, extracranial ICA is involved, IV thrombolysis is not going to work. The chance of reopening is about 2 to 3%. So in these cases, you have to do mechanical thrombectomy. Otherwise, that vessel is, it's not going to reperfuse. You're going to infarct, and IV drugs will not work. IV drugs are good for more distal thrombosis, the M2, M3, even M1. M1 also about 25 to 30% open up with tenecteplase. And it all depends on the clot size. It depends on the clot porosity. So, there are so many factors. But then when there's a huge clot like this from the extracranial ICA, it is not going to open. Forget it. It's not going to open. And maybe you can do, even for mechanical thrombectomy, if you read the American literature, they would say do thrombectomy even in 90-year-old. For us, because of costs and logistics and whatever, it becomes difficult. But if you see the indication, yes, definite indication for mechanical thrombectomy for large thrombi like this. No doubt, absolutely no doubt about that. Dr. Jaco?
In fact, actually, we had one of our consultants recently. We had a very similar patient, and we went straight away went for thrombectomy. We even didn't give her the bridging, and she has done well.
Last week, a doctor was in the basilar. We did the cath lab was occupied. We did we gave tenecteplase, and then in half an hour we had to do the pulse. And conscious, he is walking. Excellent recovery. It's a bridging. Both were given the last week only. A doctor's father, so the communication, and it's very easy. In 3 hours, the mechanical thrombectomy could be done after initial IV.
Thank you, sir. This was for my topic.
Yeah. That infarct which you showed, Dr. Chandra, yes, that was expected, that ACA MRI, initial MRI showed a small infarct, but that is because you did it early.
Yes, sir.
And, the infarct had not developed. It's not a re-stroke.
Yes.
I heard you mention somewhere that it was a re-stroke. It's not a re-stroke. It's just that the infarct is seen now.
Yes, sir.
And it is seen because MRI is done early. It's done within 1 hour, as you said, which was very good. And your door to needle time is excellent. 20 minutes is superb. I must congratulate you for that. But with such a large thrombus, it is inevitable that the ACA and MCA will go. Luckily, the anterior part of the MCA is relatively spared. So that is why he survived, because otherwise these patients don't do well. ACA, if whole ACA goes, whole MCA goes, unlikely that they would survive. So because only part of the MCA is involved, maybe how much? 1/2, perhaps. So that's why he survived. I expect that he will be disabled and he would not be able to walk, or he'll be maybe able to walk later on with little support. But his cardiac condition is also not so good. So later on, there would be indication to put him on anticoagulant, because aspirin is not going to work for AF. Aspirin, clopidogrel, when you give in combination for AF, the risk of bleeding is the same as anticoagulation without reducing the risk. It does not reduce the risk, but it produces the same amount of bleeding. So, we are scared to give anticoagulation, but we give dual antiplatelet for AF. It doesn't work. It's not indicated. you should not give it because the risk of bleeding is the same as anticoagulation. So what's the point? And it doesn't work. So he's likely to re-embolize. So, and obviously this has come from the left atrium. Even though you don't see the clot on echo, sometimes you don't see the clot on echo on transthoracic. You may see it on T, but even why do you need to see it? I mean, you know that there is AF and there's a large infarct like this and a huge thrombus. It has to be AF. It has to be from the LA or a LA appendage. So that's how I would look at it. And maybe if he's doing well and mobile and this, maybe I would think of, 110, depending on his creatinine clearance and age of course is high. So maybe use 110 of dabigatran later on. Definitely I would not use 150. Anyway, after the age of 80, it's not to be used, but there's no advantage in giving aspirin.
Sir, actually, bleeding risk according to Hasbled score at the time of discharge.
Yeah, but the Hasbled score can change. You can decrease. The Hasbled score is, equally bad for the antiplatelet also. You can control blood pressure, you can control diabetes, you can improve renal function if it can, or hepatic function. So, Hasbled score is not, written in stone. It can be reduced over by intervention. And then maybe you can, so you have to weigh the pros and cons, these people have recurrent falls, they're 90, they can have DVT, they can have umpteen problems. So, you cannot make a generalization that, give anticoagulation. You have to do it on a case-to-case basis and, see what is best for the patient. If he's mobile and all, after some time with a walker or stick or something, I would certainly consider. But if he's in bed and, dependent and MRS is 4 and 5, then perhaps I wouldn't. I would expect his MRS to be more than 3 in this case, even at 3 months.
What about apixaban? Lower dose like 2.5
yeah, maybe you can give that. Yeah, you can give that because it's found to be safer, especially with renal dysfunction. Only thing is there's no antidote, proper, but overall it's found to be little safer. So yes,
so I think apixaban, because she's more than 80, so I think apixaban will be the drug of choice.
Yeah, I would agree with that. Yes, I would agree.
And in fact, actually, even for dabigatran, I think the Prexpine is no longer getting available. I don't know how, because recently we have not used Prexpine.
I have not used for some time. Thank God
so
for that.
I'm not sure, because even this dabigatran one, the lower doses are not available. And I think most likely they have taken it away from the market. So
no, 75 is not available.
75 is not available.
75. But there's not much data with 75.
So I think...
I would say, yes, apixaban would be a better choice than I would agree with that. Yeah. And
actually, the other point is that when you are calculating CHA-2DS2, even the same factors which are important for CHA-2DS2, the same factors are there for Hasbled.
Exactly.
So you have to take a call. You can't, Hasbled doesn't really lead us anywhere, because if you see diabetes, blood pressure, everything are there in CHA-2DS2, and same thing is in Hasbled.
But if you have had a stroke, means your CHA-2DS2 is more than 2, means it is anticoagulant. No point in seeing blood pressure and female sex and age and this and that. The CHA-2DS2 will go to 7. If it is secondary prevention, finished. CHA score is more than 2. CHA-2DS2 score is more than 2. Indication for anticoagulation. Now, whether you should use it in that particular patient, that we have to see according to patient profile. Okay, so we had a wonderful discussion. Anything more? Dr. Chacko, Dr. Rodgi, anything more you want to say?
I think we have covered everything. I think he's put very, very pertinent questions.
Yes.
All the questions were very, 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 very relevant. And I think we have had a very good discussion.
Yeah. Yeah, I second that.
Thank
Okay,
you.
thank you, Dr. Chandra.
Thank
We'll
you.
go on to the next case. Dr. Keyur, are you there? We can't see you.
Yes, sir, I'm there.
Yeah.
Should I share my screen?
Yeah, please.
Dr. Chandra, please. So I'm going to present a case of malignant CVD, what I term it with. Am I audible?
Yes.
Yeah, my slides are visible, hopefully. So he's a young male and he wake up with a headache since 8 a.m. in morning. No headache on previous night when he went to the sleep. Immediately had vomiting and reached to the hospital within 2 hours. While going under scan, developed right-sided weakness. This all happening within 2.5 hours. This is the initial scan. Patient is violent in the scan with right side hemiparesis, agitated. Only plain scan was done. Parenchyma is largely okay, and there is a sinus occlusion, superficial as well as deep sinuses. All are occluded. All sinuses are occluded. Here also, straight sinus. And patient didn't allow for any detailed scans. And with scan power of right side, it becomes 0 and left side, it becomes 2. Immediately, call was taken to transfer for direct endovascular management. Only one shot of Plexan given at that hospital. When we received patient is responsive and within few minutes started convulsive status. So all this happened within 4 hours or so of starting headache. First experienced headache at 8 a.m. and up to 12:30 he's in status. So we went ahead with the DSA. It's an arterial phase. No venous sinuses at all. Nothing. Only the superficial vein is filling the right jugular sinus, but no intracranial venous outflow at all. No superficial and no deep. Nothing. Same thing in a different circulation. Only arterial phase is visible even on the vertebral basilar injection. All outflow tracks are. So immediately decision taken to go for endovascular therapy. So we track the catheter from IVC to right atrium to superior vena cava. There is one catheter in artery to check for the shoot during the procedure. The wire is coming up in right sided vessel. It's taking up into venous system. Crossing from IJV to jugular sinuses. The large bore guide catheter is being tracked over the wire. So little bit filling of the sinus, very minor. Now wire is taken into fibula to the transverse sinus. We are seeing a anteroposterior view. In lateral view, this is the position of the catheter from transfer to the superior sagittal sinus. Here to, and then it will to the superior sagittal sinus. It's taken the clot. We macerated the clot with the wire with to and fro motion. Now the large bore catheter is going up into superior sagittal sinus. The wire has been removed. So ultimately, this is the position of large bore catheter from groin to the superior sagittal sinus. From there is one micro catheter going up to the proximal part of frontal part of superior sagittal sinus. We injected RTPA 1 mg at 5 different sites, total 5 mg bolus, and rest of the 12 milligram out of 15, rest of the 12 milligram given as a infusion for 1 mg per hour. So next 12 hours, patient was sedated, intubated with all this catheter inside the brain, and that's why patient need to be sedated. And anyway, he is in status, so we have to go for all these things. And this is the deck suit after 12 hours. You can see the faint antegrade filling of the sinus and both the transverse sinus. So trach has been recanalization. Passage has been done. This is the lateral view. You can see the track of the contrast going from the superior sagittal sinus to the near and from the transverse sigmoid to the IJV. This is the post-procedure scan showing some amount of hypodensity. Patient developed right-sided weakness earlier, so most probably the cortical veins from sinus is got affected and resulting into venous infarct, more on the left side. This is the patient on next day, out of status, conscious, following command,
right side
but not
जबान अंदर
the right
रखो,
side.
जबान अंदर रखो.
And
इधर देखो.
the picture this side is on day 7. Patient is conscious. All the power
उठाने की कोशिश कीजिए.
almost 4+ on the day 7.
ये वाला उठाइए. जबान दिखाओ.
So when we review literature, there are CVT gradings. It is not well prescribed. It is prescribed by the INR department from KM Hospital way back. One paper of a very small series. So they have given clinical grading as well as DSS grading. And I think major neurological deficit but fully responsive is 3. Apart them after that 4 with impaired consciousness. As far as DSC grading is concerned, dural sinus occlusion with deep venous system involvement. So deep venous system involvement is associated with impaired alertness, and generally it is associated with a very poor outcome. As per the guideline, we generally start with anticoagulation, and if it is not working, then we go for endovascular. So it is of a rare occurrence, even in my practice also. But here the patient developed all the symptoms within 4.5 hours. So immediately we went up for the endovascular treatment. And afterwards on etiological workup found to be hemoglobin of 16, 60 of hemocysteine. Patient was alcoholic and has taken a binge drinking 2 days prior to the starting of the illness. Apart from that, all anticoagulation workup was negative. So this is one of the cases where we use the thrombolytics for venous side, but not the arterial side. I am open for any comments to the case.
Can you tell me how much dose did you use? I just missed that part.
We have opened a 20 milligram vial, 20 milligram of RTPA, and we generally give 5 milligram as a bolus on different side. Where we inject from microcatheter, we withdraw microcatheter 2 centimeter with 1 mg bolus. We give 5 mg bolus, and when we reach mid-sagittal sinus, then we keep it there and infuse as 1 milligram per hour for next 12 hours also. So total 70 milligram.
Almost 17 milligrams of.
Yes,
this was Actilize you gave.
Actilize, yes, sir.
Actilize.
Because as of now, whatever small case series is with Actilize only. Previously, we used to use urokinase, but it is not available now. So we have switched to actylase.
Okay. Some of our, in fact, in 1 or 2 meetings before, we had people using even tenecteplase for intra-arterial this thing, not for venous, of course. So
It is actually a better molecule for intra-arterial.
it is
Tenecteplase is even a better molecule for intra-arterial.
okay. And for
Because
intravenous, there is
we require very small doses for intra-arterial. So we have been using before trial also. Being endovascularist, we generally have some complication of thrombus formation over stent and distal migration. Going with the previous case comments, we have one patient of low diorder on ecosprin and brillianta, put a pro diorder, thrombus formation was there, a small thrombus formation. We given tyrokiban over that with ecosprin in, brillianta loading dose in, and tyrokiban given. Patient has a recent subarachnoid hemorrhage. Tyrokiban given, so clot is dislodged and migrated upward and blocked the dominant branch of left MCA, the frontal branch. So Broca's area is at risk. So with a patient of SH on ecosprin, brillianta, tyrokiban, and then we injected a small dose of tenecteplase.
you are really very brave.
It is one of the heroics, but generally we do it because most of time it is a one table stroke and we don't expect much of the tissue injury and impact size. So we take that liberty. Most of the other op papers, but this is being done.
Anyway, very interesting.
Any comment for Icha Buria, sir?
Hello.
Yes, sir.
Yeah, you didn't do the thrombectomy, no, in this one?
No, we remove thrombus, sir. When the guiding catheter goes to the superior, we generally try to shuck it out. But most of time, that is a futile exercise. Sometimes just vacuum comes out, none of the thrombus because of the opposition of the sinus. It doesn't have that great wall, so it gets reconciled. And sometimes the clots gets coming because once we give space, some new blood comes, immediately clots, but at least it gives some respite to the medicine to act. So we try to...
because some people, as I remember, some people have used penumbra to suck out the clot, because if the clot is friable and soft, because it's so acute, so it's likely to be very soft and acute and red.
There is one technical consideration into it. When we use Solumbra, we are committed to the cost of the Solumbra. Here, when we are not committed to thrombosuction, we generally take the catheter, which is cost effective. Here, my catheter comes around 30,000. When we use the Solumbra catheters, it comes around 1 lakh to 1,10,000.
Yeah, cost is a factor.
Yeah,
but I'm just saying that I think Vikram Huded has shown few cases.
People are doing thrombosuction, but because this catheter is not meant for the suction. When you apply suction, the wall of the catheter itself gets opposed and there is no transmission of suction pressure in such kind of catheters. But here we are committed to lysis, and by and large we are because we are doing lysis for around 10 years or so for CVT, and that these catheters are in the market for last 4 or 5 years. So we are used to deal with lysis and we are getting good results. Only disadvantage, patient has to be sedated and has to be in a good setup to do all this, because all the catheter in sedated patient, even a slightest movement can lead to disaster. So it has to be in a good center. Otherwise, thrombosuction will be much effective when centers and ICU care is not up to the mark. You just get the procedure done and come out.
Yeah.
Sir, regarding last case, what is your take on the thrombolysis with the cardiologists are now using antiplatelet with 2.5 BD apixaban regularly for severe carotid disease, coronary diseases? If such patient comes, so 2.5 BD really counts as a contraindication or what?
I think the cardiologists are giving it because in patients who are having an underlying CAD, they are giving a combination of apixaban with
Yes, sir.
clopidogrel.
Yes, sir.
So, but in this patient, I think in this particular patient, because she was having a simple atrial fibrillation more than 80, I think
Not that patient. I'm not talking about that patient, sir. Because with the recent trial, the prescribing pattern has changed tremendously. Most of the patient, other than on dual validated on single antiplatelet with apixaban 2.5 BD. If such patients come with a stroke and we are supposed to lyse, then should we count apixaban is a proper therapeutic anticoagulation dose or what? Or can we go ahead with lysis?
I think it will be very difficult because the chances of bleeding in such a patient would be very, very high.
Because it's not being studied as such in any setup, but we are in dilemma because many patients are now coming with this kind of combinations.
Yeah, because in cardiology, it is a very common practice to use this combination of 2.5 mg apixaban and clopidogrel. I think that's a good question. And we don't have any real answer for this.
We'll end up with a similar case recently. That was a right M1 occlusion. We go ahead with the lysis with explaining all the thing. We don't have any other data, but it was within 2 hours and very small cortical signs on CT. So we go ahead with lysis. Luckily, it opened up, but that is the issue now. How to go ahead with such kind of patients. Ichapure sir, any comments on this?
No, I don't know. And this 2.5 and clopidogrel combination, can you thrombolize? I don't think so. I mean, I wouldn't.
Yeah, but that was right M1, and luckily they are the daughter-in-law is a pediatrician, and we discuss all the complexity.
All these are very gray areas. There is no proper data. I mean, you have to do it on case-to-case basis.
And cardiologists never think about what difficulties.
Yeah, I know they're doing it, but we cannot make a statement on this.
Yes, sir. But
do it or don't do it.
Very fast because more and more patients are coming up with this combination. They are now using it right and left. This apixaban 2.5 BD. So I think this issue will be coming more and more often to us.
Absolutely. I think this will be I think it's a very good question because we don't have any clear-cut guideline. I think what Dr. Ichapuria was last time telling that maybe a PT may help, PT INR may help, but this is actually a very small dose. I don't know whether PT INR would also make any difference or not.
Yeah, but for apixaban, I didn't know this till we had one bleed with apixaban that for dabigatran we do APTT. But for apixaban you should do PT. So, and for rivaroxaban, we are not sure exactly PT or what, how to determine because we don't have the drug assay. So for apixaban it's PT. So that's a useful thing I learned few weeks ago, which is different. So maybe in these cases you can do, and then I don't know how well you can reverse with PCC, and I mean it's messy. Definitely, it's not straightforward. It's messy. It's a messy issue. So we don't have an answer properly to give the audience. The jury's out. Yeah, but I must say, Keyur, very good case, and you took a lot of initiative and a lot of guts to do what you did. But part of the decreased sensorium could be because he was in status also.
Yes, sir.
He was in status, and he could be, and maybe possible. he was on sedatives. Sedatives means drugs for status. So the neuro assessment, becomes very difficult.
Yeah, but here, sir, what helped us is there is a right-sided weakness. There is a complete focal finding of right-sided weakness. And within around half an hour or so, coming out of scan, had left-side weakness also. And by that time, there was no overt seizure. Patient referred to us with a weakness only, and within half an hour or so, started convulsing. So obviously, CVT convulsion is also one of the relative, I will say, contraindication for endovascular until the seizures get settled, because most of the part is post-ictal. But here we are left with no choice. A young male with such kind of fluoride course over 4 hours. So neurologist immediately referred to endovascular only. Luckily, we have good result there. But generally, we avoid patient with active seizures as well as mass effect and large bleed kind of thing for endovascular, because the reason for deterioration is different here than a venous congestion. Ideal patients are with venous congestion and a properly good kind of CT scores.
Without intervention, the disease worsens like a traffic jam. It might involve the vision, and the patient already in status and severe headache. Only if we can intervene at the circulation restarts will there be any benefit.
Yeah. Okay. So we are running out of time, I think, and we've had 2 very wonderful cases, and KU has shown a very fascinating case, and I really don't know what I would have done in such a case, but maybe you've been very proactive and aggressive, and congratulations for that. And patient did so well, so it's so very gratifying.
All thanks to, sir, your lecture at KEM Hospital where I was resident.
Lecture, yeah. Anyway, so congratulations and well done. And really, you took the bull by the horns. And wonderful. So we learned so much, every such session we learned something, and really we are enlightened. And maybe next time I get a case like this, Keyur, I'll think of you and maybe talk to you about what is to be done, because our back is to the wall in such patients. So excellent. I'll now hand it over back to Ajinkya. Ajinkya?
Yes, sir. Thank you so much. As you said, sir, we have learned so much from this workshop, and there are few questions in the comment section.
Yeah.
We are already running out of time, but if you allow,
never
we can
mind. Take all the questions.
Yeah. So these questions are for the, I guess, second case. So Dr. Pankaj Singh has asked, what was the clinical and radiological indication of starting with the endovascular procedure of macerating of the thrombus? What was the clinical and radiological indication?
Only one case series of KM paper is available. They have given the grading, what I shared in my workplace.
Yeah.
So they have conjugated it like anything in a grade 4, 5, or 6. That is a patient with altered sensorium and deep venous system affection. They have gone for the endovascular. Anything below 4, like grade 2, 3, or 1, any deterioration after 2 doses or 24 hours after the full dose of anticoagulation, they have gone for the endovascular. Here, my case goes for the stage 5 or 6. So, and it's rapidly progressive. We have to do something. So we have gone ahead with the endovascular.
Okay. Thank you so much, sir. I think you have answered for the second question. The second question is why you didn't do the thrombosuction or thrombectomy. I think you have already answered that. Just please, yeah. Hello, sir. The second question was why you didn't do the thrombosuction or thrombectomy in this patient.
He's answered that question.
Yeah. He has answered that. So that's all, I think. Yeah, total 9. So I am very happy to announce that, sir. Our total live view count has been for today is more than 375. So
I think that's really good. Really good.
375, sir. Yeah.
Oh, that's very good.
So I hope all those 375s have learned something.
Absolutely, sir. Absolutely. They must have learned so many things. So as usual, it was a very wonderful workshop. And I would like to thank Dr. Panchal sir, Dr. Umesh Chandra sir for presenting those interesting cases. And I would like to congratulate them as well. And thank you so much, Ichapuria sir, for guiding us yet again. Dr. Rothki sir, Dr. Piju Chako sir, for your expert comments and your great practical insights. And we would really like to work under your such guidance for many such future programs, sir. So with this short note, we will close this session. Thank you everyone again. Bye bye.
Thank you. Good night.
Good night.
Thank you.
Right.
Bye.